I'm Duane Schulthess, and on this Vital Health podcast at the Gastein Health Conference, I'm speaking with three well-known leaders in healthcare. We'll discuss what the EU needs to do to balance the needs of a growing, aging population suffering from non-communicable diseases while addressing inequalities and leveraging technological innovations. Hopefully, this will improve the quality, resiliency, and sustainability of Europe's healthcare systems. I'm very pleased to be joined by Francesca Colombo of the OECD Head of Health. Francesca, it's been a while. It's great to see you.
Great to see you.
Joining us remotely is Annemiek Verkamman, the Managing Director of HollandBIO. Annemiek, how are you?
I'm good. Hi, everybody.
Thank you for joining us. And of course, Josep Figueras, the Director and Founder of the European Observatory on Health Systems and Policies. Josep, always a pleasure, sir.
Good to be here.
So while we're nestled here in the valley of the Austrian Alps, it's absolutely stunning. It's hard to think that there are any problems at all in the world, but in reality, there's aging populations and increasing rates of non-communicable diseases, cardiovascular disease and cancer. These are putting tremendous pressures on the healthcare systems across the EU. NCDs cause over 90% of premature deaths and 85% of the disease burden. The four highest disease burden non-communicable diseases estimated to account for 25% of spending, almost 2% of total EU GDP. So, Josep, what are countries doing to address this? What can they do more of?
That's a question we need several podcasts, Duane.
Well, we can start today, I hope.
To say the least. Let me go back to basics for a second, actually. Let's remind ourselves. Behavioral risk factors.
Okay.
We know, the work that Francesca and I, my partner in crime here, the EU Health Profiles, we're doing together for the EU member states. So, around 35-40% of the mortality is explained by the usual risk factors: alcohol, tobacco, diet, and environment. I think it's 17% on average in the EU for alcohol, and the same for tobacco, and those are preventable. That's not new, Duane. We've been talking about that announcing for years, if not decades.
Yeah.
We're still saying the same thing. These are there, and they are preventable. We know as well, and that becomes more complex to address, but that's where we need to go, that these risk factors are determined by all these socioeconomic determinants outside the health system: environment, education, housing, economics, and so on and so forth.
And age.
And age, but I'm talking about the things I can change. Age I cannot change.
Okay.
The others I can change. No, I wish I could change. I cannot change. Francesca and I do our very best to convince our policymakers, right?
Yes.
And we do what we can. And the debate still is. It's just, I feel going back, to square one every day. The debate still today, Duane, is between the individual choice. We need to allow the individual to decide his own or her own behavior, which is fine, vis-a-vis the regulation, taxation, and all these other elements. What the neoliberals will call the nanny state. I won't call it that way. So what can we do about that? We can go into the secondary prevention. We can go into healthcare. My partner in crime here again, OECD, has excellent data in this area as well. They're talking about 3% now. It's increased a bit, right, Francesca? The percentage of expenditure goes into prevention. To me, that's fine. It's very little. Should be much more. Much more you can do in primary healthcare, integrating public health, and so on and so forth. But the measures that are working, and we are behind. One that is the only one actually we talk about all the time is the Framework Tobacco Convention.
Yeah.
Why, Duane, is taking so many years to pass? I know the answer is very clear, but yet I'm going to make
It's a rhetorical question.
It's a rhetorical question.
But we'll use it. Go ahead.
But just tell me why, and then you'll know why the NCDs are here. Why? How many years it's taken us to implement the Framework on Tobacco Convention, which has an impact on cancer and non-communicable diseases, a massive impact. Why? If you answer me the why, then we can go home because we know what we need to do. There have been improvements. Taxes to sugar, for instance, to fizzy drinks, labeling, we've gone much better at that. Some countries are banning children advertising.
Sure.
It's one of the effective measures that we have in there, labeling food content and so on. The issue here is, and the public health committee keeps saying that, we keep saying that, we've been even in Parliament doing conferences, meetings, we had that in UFA last year, European Public Health Conference. Yesterday, I came out in plenary which is the commercial determinants of health. Duane, 1/3 of deaths that are preventable, 1/3 of all deaths, we're talking about lots of deaths, could be prevented. I'm not talking even morbidity, I'm talking just mortality. Tobacco, alcohol, fossil fuels, and processed food. What are we talking about? These companies, some of them have larger GDPs than some of our small median EU countries in this region.
Well, hold that thought. Let me bring in Francesca now, because what we're talking about now is alignment and policy. How do we deal with these inequalities about trying to align policy? The countries need to be aligning. What can practically be done?
I think, Josep, you mentioned and alluded to all the issues, but as a first thing, as a reminder that there are very significant inequalities in outcomes by different markers of socioeconomic differences, or by education level, by income, by occupational status, and so forth. And those are really quite significant. I mean, if you look at self-reported health by education status, they different across countries by a factor of 2. Or if you look at differences in life expectancies by socioeconomic differences like education level, well, we find that there is differences in up to 6 years across countries. Or even if we look at cancer outcomes, those with lower education, men or women, have a much higher probability of dying. So there are things that can be done by clearly addressing factors which should be the starting point of health policy, which is really the prevention. And I think that's what very, very powerfully has been alluded to by Joseph. Joseph, you did mention that, yes, we do spend on prevention a little bit more following COVID, but actually a lot of this is really... It is still incredibly little, but a lot of it is really going for COVID vaccines, or for testing. If you take those out, the underlying trends in spending in primary preventions, also in secondary prevention, still remains really, really very small, less than 3% of total health expenditure, and will not really stop, saying that if we want to address NCDs, if we want to address the huge and unacceptable inequalities in outcomes from NCDs, we must start from there. We must prioritize investments in preventions to address those gaps.
But Francesca, I agree with you 100%. I agree. I mean, we always agree. But what is prevention here? I'm talking about, we can work on socioeconomic determinants. Ultimately, these differences in access have to do with the health system. You and I have been working on that. There's a lot we can do. But ultimately have to do with socioeconomics, with wealth. I mean, Michael Marmot in all his various reports, he ends up that we need to change the taxation system. We have to change societies. Which I agree with him. However,
that'll be easy.
That will be easy. Exactly.
So I'm
going into nanny-state, if you want to call it that way. We need to regulate.
Let me jump in here, because what you're both saying is I see a tug of war here between how much power Brussels has and still the idea that the mandate is at the state level,
at the
member state level. There's a tension there. Now, there are some programs at the member state level, the German Decade of Cancer, etc. Are these a way forward, Francesca, or do you see...
It's a start.
It's a start.
It's a start. I mean, it's a start by saying, and there indeed we see innovative things like food labeling, which is happening. We see much more attention to having, more promotion or healthy behavior, particularly targeting, children, for example, when we're talking about even harmful alcohol consumption, so preventing and banning exposure to, communications from companies, particularly for those groups, or pricing policies. You mentioned obviously taxations and so forth. We do see things that are happening, but comprehensive packages that address both a mix of what can be done within the health system, what primary healthcare can do, what the physician can do, what can be done outside of it through fiscal policies, through then obviously education, and even outside. I mean, if you talk about alcohol prevention, you need to also regulate drinking and driving. So there are things and policies that happens outside. And are we there yet? No. No, because the data tell us that we're just not there. I mean, it's very simple as that. We need to keep on innovating as well, and we need to keep on evaluating how those innovations, including on things like food labeling, are working. Are there any way more granular in which we want to do the food labeling that seems to be more effective? Obviously, they have the Nutri-Score, for example, in Europe. Outside Europe, there are different approaches as well. So it's not just even enough to say, okay, we have implemented those, if you want, tick box interventions that we know from modeling exercise, including what we do at OECD, that are the ones that will make a difference. We also need to evaluate in very granular way what's the design features of those policies that does make the most impact.
And I would think the effectiveness then as well. There
Absolutely.
needs to be some arbiter over what is effective, what works and what doesn't, and what's useful and what isn't. Josep, you want to quickly jump in?
Today I have a political economy day. I mean, I'm in research and evidence like Francesca, but today I have a political economy day. It's not Europe or member states, Duane. It's commercial vested interests. How many countries that produce beer, I will forget the names right now just to be politically correct, have blocked messages, healthy messages, health warnings, I meant, in the bottles of beer? How many ministries of health I talked to that tried to put the amount of calories in beer and wine and have been blocked by the industry? EU is putting in place a range of legislation that could apply because of the internal market across countries. And I know the civil servants behind that. And I know that many member states, some member states would agree, but still the vested interests of the other part of the EU, which is the economic part, are blocking that. That's what we're talking about. What is the role of labeling and effectiveness and so on, and there's a lot of uncertainty and a lot of certainty. But even with certainty, why we still allow, and you make the great point again, still so mild childhood advertising? Not only on television, no one cares about television these days, it's all about digital.
It's internet, it's online.
Isn't that something member states should be blocking, should be regulating? Is it a nanny state? Is it children have the free choice, to decide whether the hidden advertisement in their sort of cartoons and other messages, they have to discern it? Come on.
But we have examples of programs, and we alluded to the German Decade of Cancer. There are programs that have worked.
Of course.
I would like to, Annemiek, obviously, Annemiek, I'd like to come to you now. In your role as the head of HollandBIO, obviously the Netherlands is an exceptionally strong global innovator in new technologies. There have been several key national funds that have been doing very good to bring new innovations to deal with at least one part of this problem, which is the growing issue of cancer. Heart attacks and heart disease were number one killers. Soon, with the growth rates and the aging population, cancer is going to overtake that. We have Italy's Fund for Innovative Medicines, the UK Cancer Drug Fund, obviously not part of the EU anymore, but certainly a flagship program, and France's early access programs. Do you see a need or an opportunity for more countries to do this? How effective have they been for your members, Annemiek?
Yes, a good question. And first, I think it's important to state that I'm completely also in favor. I think it's important to promote prevention, because that's where health started, and that's why I really enjoyed the discussion so far. But sometimes people do get sick, and when you are sick, you only want one thing, and that's to get better. And what we see in the Netherlands is that we absolutely have an innovative country with an innovative biotech sector, but we also see that the access for patients to innovative medicines is delayed. And this is an important issue, because these patients are typically patients with urgent needs and they have limited options. So I think in general, it should be our common goal to get new scientific insights and innovations as soon as possible for the benefit of society and patients. What we do not have in the Netherlands is an innovative fund to bridge the gap between the development of new medicines and patients. And that's something some countries do have that in place, and I think that works very well, because it's a structured mechanism to introduce high-cost and high-impact therapies to the market sooner. But introducing such a fund that should go together with new methods to collect real-world data on their effectiveness and impact. I think that's something which is still lacking in our healthcare systems, because then we can also bridge the knowledge we gain from patients who have a therapy, and we can also collect data and improve the healthcare system. We should introduce a learning loop. And now what we see, at least in the Netherlands, that the prevention part is separate from cure. And I think what we need in Europe is a more integrated system to look at prevention and cure and general health. That then also will lead to a more efficient resource allocation.
Josep, you want to jump in?
I wanted to ask you a question. May I take your job?
Yeah, please, by all means.
Why we don't have more innovation in prevention? I know the answer, but I like your answer. Why are we not putting enough money into innovating in prevention in forms of communication, for instance? Even genomics, although I have my worries at genomics, but more than genomics, what about using AI? Actually, in the European Public Health Conference, we're going to have a plenary on AI in public health, sort of risk assessment, risk detection, ways to improve the messaging and understanding the views of our population out there and target our messages to them. Yeah. Why we're not putting money into that? Can I have an answer from all of you?
Let me jump in here and take my moderator privilege back. But, if you look at AI funding with the legislation that was passed by Thierry Breton, you see Europe now has 1/50th
Breton is no longer there, by the way.
Well, I'm sure everything's fixed. But you've got 1/50th of the investing right now in AI, according to data from PitchBook I pulled, in Europe compared to the US. It's crushed AI investments in Europe. And then you have the combination with, and I'm sure the GDPR has very good motivations for being there, but you've also stifled a lot of innovation for data usage here. I agree with you completely. And the problem is Europe is getting left behind by the United States and Asia in this space of uniting AI and prevention. Francesca, you're nodding a bit. I mean, what's your opinion on this?
Clearly there are different frameworks, including regulatory frameworks and different approaches, to the use of AI more broadly. And much more, first, let's make sure that privacy is respected, and then the risks are reduced at the maximum, and then the innovations, and the other way around in UK, US, or other countries. I think it's a little bit too early just to say, okay, which approach is really going to work the best. To me, what is going to be fundamental is to have much more, if you want, a post-marketing evaluation and surveillance about what is the effect of all these new tools from artificial intelligence. Where are we getting the greatest results in terms of improved health? Where are there risks, safety, that obviously will require, going in perhaps and saying that tool should not be used anymore. But we need to have a much more thorough and more adaptable way for evaluating those new products once they are introduced, even if they have passed all the tick boxes of the more stringent regulatory approaches of the EU. We'll need to do that, and we'll need to identify those also innovations which are the most valuable, and make sure that they are scaled, because there is an awful lot of fragmentations, things which are really happening in very, tiny pockets within the health systems. And we run the risk of not leveraging things that might make a huge difference to improve outcomes, to reduce cost or improving efficiencies, if we're not identifying where are, the superstars in a way, and trying to make sure that they can be also scaled up.
Annemiek's at the corner with a lot of these superstars, and I'd like to loop back to you. What is lacking from the use of data for the availability for your innovative capacity with your members? And how can we use that to better align prevention with what you're trying to do to cure these very difficult conditions? How do we put this together to make your innovative capacity with your membership more effective?
Yeah, I love this discussion because it's so important. At the moment, I think that Google and probably Apple know more about my health status than my own healthcare providers, because we are just sending our data all over the world and not using it in Europe. So what we need in the Netherlands, but also in Europe, is a robust healthcare data system. And we are not doing so because of all kinds of reasons of GDPR. And of course, you have to make sure that these things, that everything you do is aligned. But it's now very often what I feel, the privacy legislation is an excuse to do nothing. If we build a good data system, what's in it for my companies, I can be honest about that because I represent the biotech companies. For companies, it would be important to that it is possible to use secondary data, so which are not coupled to a personal level. Because if you have these secondary data and you can use them for research, you can discover trends and new developments. You can combine genomics with behavior, because my behavior is also recorded by my phone. And I'm sure that with AI, we can draw new conclusions from these enormous large amounts of data. Up till now, it was simply not possible for us to find meaningful relations in such large data sets. But now it's getting possible. But we need this data healthcare system. And for companies, as I stated, it's important to, and also for researchers in university, that you have access to secondary data. And I think if we don't fix this, we are not going to win we are real lagging behind as Europe. And it's super important for our future health. And the data system can also help in defining which kind of therapies will be beneficial for different patients. And that will make our healthcare system better. And we can also use this to determine early access programs, because when we are able to identify the patients for which a new therapy will be best, we can cure patients faster. And also my wish is to decrease the development times, because what's driving the prices in new therapies, it's the long development times and the high cost and the high opportunity cost. So the only way to get the costs down for new therapies is to do it faster and better.
No, I agree with you. But what do you think about the European health data space? I mean, we all hailing that as a major development forward. I mean, we do all agree, and I think your point is very powerful, about the need of that access to data, secondary data, and so on when it's anonymized. And you're indeed right, absolutely right, that we'll never be competitive as a continent vis-a-vis the United States, and definitely other continents like China or countries where these issues are
negligible.
Are negligible. So I totally agree with you. At the same time, of course, I mean, the concerns of AI actually suggest that you guys read the volume Nexus from an anthropologist, from an historian, our famous Harari, his latest book. It really goes into this issue of data, intelligence, what's information, and what is truth as well. Anyway, so there are all these elements in AI that we need to thresh out, but I'm sure we all agree on that. But don't you think that with the European health data space, we really done a serious leap forward, albeit it will take a long time before it's implemented, of course.
Well, as the Brits say, the proof of the pudding is in the eating. We'll need to see how it runs.
Yeah.
So, Francesca, if we look at, say, the European health data space in the context of all of the discussions around COVID-19 and building around the collaboration in COVID-19, where are we at right now with those collaborative efforts? How are we doing to align that with national healthcare systems? How's that going?
Definitely there is much more collaborations, which has been triggered also by COVID-19. I mean, we have finally discovered that health and health systems are fundamental, that we not just can say that those are national responsibilities, that if we want to be better prepared for future threats, but even for long-ranging trends in changing chronic diseases and so forth, we need just to work together as a Europe. I think there is much more by way of cross-border collaboration, which is incredibly promising, including in areas of NCDs and chronic conditions. There is European Cancer Imaging Initiative, for example, that was launched recently with the idea to have an open infrastructure for cancer images. I mean, that is a way forward. It's just saying, okay, let's put together data, information and so forth to help improving diagnosis by leveraging also algorithm and what artificial intelligence can do. There are, obviously more collaborations also in terms of more joint clinical assessments as part of the HTA regulations and so forth. There is, the European health data space is going to be, if it, put into place and work, is going to be very, very powerful. Yes, you're looking at me. But
well, say if it has teeth. If it has teeth.
If it has teeth. But to me, maybe I'm an optimistic, but the promise is there. I mean, if we're talking about leveraging the power of data, and it is true, it's not just linking data from health system, but with things like genomics, the deep research data in a much more powerful and privacy protective way. Well, the opportunities for research, innovations, improving detection, and you name it, and cure are just immense. Mm-hmm. So yes, it needs to have teeth. At the same time, the teeth are on both sides, both in terms of the protections that you want to have, but in terms of the facilitating the use and the linkages and the secondary use of data.
No, Josep, I know you've done a lot of research on this space, and I'm going to come back to you. But first, I want to ask Annemiek, from your practical point, your perch, dealing with biotech companies, has the rhetoric around unifying processes post-COVID for your membership, is the rhetoric meeting reality on the road, or is it still more hot air than practicality? What's your feeling on this?
The first one, because when talking about these subjects, what I feel is that we are moving in the right direction, but I often feel that we are not ambitious enough and not bold enough, but that's something what's happening in Europe. If you want to drive innovation is typically something which comes with taking risks. But in Europe, we have a system that we want to have broad consensus. And these two things, innovation and broad consensus, do not, let's say it this way, strengthen each other.
Well, depends what consensus is about, isn't it?
I was about to say something.
Josep, you've commented a bit on the Draghi report, certainly, and you've also done a lot of research on post-COVID unification of processes. Where are we right now? What do you think is good? What do you think is bad? What do you think needs to be improved?
After COVID, wow.
I know, and we've got 5 minutes, so run with it.
We got 5 minutes. No, I think I would align exactly with what Francesca is saying. COVID has been a blessing in disguise, if you can call COVID a blessing. But a blessing perhaps because we're far, far better prepared for the next pandemic, which will be the bad one. And we all know which one it is, right, Francesca? It's the AMR. This is the one that's been knocking in our door forever. And AMR in itself is a beautiful case study. To me, it's one of the beautiful case studies, actually, we did a couple of... We've been working with the last two presidencies, the Swedish and the Belgians. We're looking at AMR. With the Swedish, we looked at, actually interesting for Annemiek, about the incentives to the industry to produce new antibiotics. So what you do, how you work with the industry, how you get, Annemiek, this win-win, which was a lot of fun. And then the OECD was also involved. And then in the last one with the Belgians, we went into the implementing. This is another question to reflect, Duane. If there is a public good, remember the concept from economics, public good?
Yes, of course.
If there is an area where there are externalities, remember externalities?
Yes.
If there's an area that subsidiarity doesn't have a role, is AMR.
Mm-hmm.
If cows, doctors, nurses, and people cross borders, makes no sense that AMR is steered in one country and not in the other because they cross borders. And we're still lagging on European regulation, not because the Commission is not able to do that, doesn't have the ECDC, doesn't have the whole data.
Yeah.
The OECD has great data on that as well. It's because the member states are not prepared to unify and have a consensus. You want an area where we need consensus, is in this one. Tell me why it's not happening.
Well, there's another economic theory called the tragedy of the commons. And unfortunately,
a very old one.
yes,
still today.
It's still today. Or beggar thy neighbor.
Up to date.
Yes.
Yeah, up to
the
date.
problem is the person who pays isn't the one who benefits. That's ultimately the problem. You have
Well, not quite. In this case, if I pay for you, I benefit. It's
long term.
It's not quite a tragedy.
But it might
quite
not.
short term. If you are a country where you give antibiotics to your cows, which is forbidden in Europe, thanks God, that we have regulated, I'm eating your cows. So I want you not to give antibiotics to your cows because I'm eating your cows.
But if we're talking about inventing new antibiotics, the person who is ultimately going to be paying for that development, which is going to run $1.6 to $2 billion, probably, they're not the one who's going to reap the long-term societal benefit.
This is where you want EU action. This is where you need to read this policy brief,
I completely
where
agree.
we actually look at a number of market incentives for the pharmaceutical companies to come on board. There's a win-win in this case.
Yeah, Annemiek, please, go ahead.
Can I comment on that?
Please.
Yeah, I think the AMR problem is a huge issue and it's a huge risk for our societies. But what I see, if I look just in my member base, we had some startup companies developing AMR, and they all got bankrupt because they couldn't get funding. There is no business model, and we are talking about alternative business models already for 15 years. You could give some kind of member, a kind of fee for having something on the shelf, just not for using it, but to pay for have something on the shelf. I think we are talking about new business models for 10, 15 years. Nothing happened. Companies go bankrupt.
Very little. There is very little, but there are something happening. I mean, UK, in Sweden. I think a big issues will be also scaling up again. I mean, it's like to really make a difference in these new business models. You have them that need to be applied, across all countries, and really to a scale that will make the incentives for industry enough to remain involved. Otherwise, we're going to heading up for disaster.
Well, ironically, the one benefit is, as we're talking about the good side of COVID, as it were, and again, that's a terrible thing to say, but the reality is some of the models around funding the vaccination development, like Warp Speed, et cetera, could be an excellent model for AMR.
But we do have, as Francesca rightly says, we have now a range. The Swedish presidency was excellent on that regard in looking at the range of mechanisms to incentivize the industry and have these win-wins. You're saying, the subscription model like in the UK, but accelerated market processes to get into the market. So there's a wide range of shared investment, like for vaccines. And I think, but as you're all saying, is the scaling up. As Francesca is saying, is the scaling up. And that is, again, when member states, because Annemiek, you should not, you're not doing that. But many people are barking at Brussels. Oh, it's Brussels. No, Brussels does what member states want. So what we need to do is lobby the Dutch, lobby each one of your member states to play together. It's not a tragedy of the commons on this one.
No.
It's not this one, actually.
But Josep, I think it's not just Europe here. I mean, here we're talking about something which is much more global.
It's a global problem.
I agree.
And the UNGA had a high-level meeting just now on antimicrobial resistance and so forth. I mean, where countries struggle is to have some binding commitments, some targets that they want to achieve, which are both in terms of rational use of antibiotics, as well as on the innovations. I think, we have been talking about this issue for a long, long time. But if you look at all the declarations also that have come up, there is nothing which is really binding commitments to really make something that we want to achieve and that countries will commit to achieve it. And it needs to be on different fronts. It needs to be on, as I said, on responsible and rational use. It needs to be on developing and use of rapid tests as well. It needs to be
rapid
on
diagnostics,
access.
100%.
It needs to be on access as well, particularly when we're talking about a global scale, and it needs to be about the innovations. But the sort of binding targets that we want to achieve. This is missing. So in a way, I think there is a lot, even at political level, that can still be done.
We're almost out of time, but I would like to just get your final thoughts here. If we're talking about how we can roll out an NCD policy effectively, what do you think is the quick win?
I don't think there are quick wins.
None.
I think is I think talking about quick wins is, even though I'm an optimist as well.
Then where do we start?
There's no quick wins. I think we need to start in the same way that, as Francesca was saying, UNGA and AMR. That's at the level we need to bring these issues. That's at the level we need to bring them with prime ministers. I know we've been saying that ad nauseam, but I think there's enough evidence now, there's enough critical mass to get this out of the usual niches and realize where the determinants lay, realize the case for investing on health and health systems. I mean, we just finished a piece of work, we've been doing a lot of work like the OECD around making a case for investing on health and health systems. We have powerful case that now is reaching the right actors, saying, NCDs is the economy. And remember, NCDs have an impact on productivity, but not on the retired, on those working.
Correct.
When you look at the absolute numbers, we have this sense, well, at the end of the day, the utilitarian perspective, if the elderly sort of have a chronic disease, who cares? They're not producing. Well, it's not true. It is actually in working age, early retirement and chronic disease and chronic sickness. So we've been saying that a long time, but we now have more of the arguments to put on the table to bring that debate outside, and it's not a quick win. And I think it's a lot of lobbying, a lot working with civil society, being much more of an activist together with the data. And I work on the data. I work on the evidence. That's what pays the bread and butter for my family. Having said that, I do believe that we need to be much more active, much more bullish, much lobbyists to get this out of the usual niche.
Annemiek, same question to you. What do we need to do? Where do you need to start?
There are many things to do, but I think a real benefit for patients who are in urgent medical need is to establish an early access funds for medicines, for therapies which are in the Netherlands, which are in the lock. That's a negotiation phase that can take up to 1, 2, 3 years. And I know that immediately the discussion will start who has to pay for this fund. So for the Netherlands, I would suggest a solution going Dutch. Split the cost.
Thank you, Annemiek. Very used to that. We'll probably practice that this afternoon and this evening. Thank you. Francesca, final word to you. What do you think?
Difficult not to repeat what says, but I would perhaps in terms of quick win, let's leverage much more powerful really the data, the longitudinal data. I think there is a lot that we can do in terms of really even like personalize public health, using artificial intelligence not just for development of new perhaps cure treatments or whatever, but to really making a difference in terms of the prevention. So maybe like being much more really doing much more in this area and trying to leap quickly the benefits, obviously controlling their cost. All the rest we have said it, the social determinants, the investment preventions, and so forth. But I think here we can have a very, very quick, very, very scalable and important wins.
Josep, always great to see you. Francesca, always a pleasure. And Annemiek, it's a pleasure meeting you virtually. Hopefully we can do this face-to-face sometime. Thank you, all of you, for your participation. It's a great conversation. Have a good day.
Thank you.
Bye-bye.
Thanks very much. Bye-bye.
Bye.
The executive producer of the Vital Health podcast is Duane Schulthess. Our audio editor is Mark Brodeen. Our video editor is Rico Molden. Our project director is Gwen O'Loughlin. This podcast has been made possible with the financial support of Merck, Sharp & Dahm. This Vital Health podcast is a production of Vital Transformation LLC, copyright 2024.